India's elderly are the fastest growing segment of the country's population. Against the backdrop of growing consumption across the board, there is merit to evaluating this demographic as an untapped opportunity. While the elderly are by no means a monolith, they do skew heavily towards spending on healthcare and away from discretionary spending, at least so far, which provides the initial lens through which we examine opportunities in this space. There are significant health challenges unique to the elderly population that are inadequately addressed today. While there is a need for services and, to a lesser extent, products to improve and expand the healthcare experience, the market for them is relatively fledgling, and existing and emerging models have not yet proven scale and sustainable economics. In our analysis of the eldercare market opportunity, we looked at the limitations and the complexities of existing segments such as home care and assisted living, and explored white spaces where elders and their children may be willing to spend. Beyond health, we're also at the starting line for an uptick in discretionary consumption by young and soon-to-be urban mid-high income elders who earn and consume more than previous generations, have an entirely different relationship with tech, and are increasingly open to planning for their elder years. Overall, there's high conviction on latent demand and the inevitability of this market. This thesis is the foundation upon which we'd like to build further views as the landscape evolves. India is experiencing a demographic shift reflective of global trends. While the country may not be aging as rapidly as developed nations like Japan or the United States, the elderly population is on the rise. The elderly currently constitute around 11% of India's 1.4 billion plus population. By 2050, though, it's estimated that more than 20% of our population will be over the age of 60. This rising share will be driven by two factors: declining fertility rates and increasing life expectancy. Eldercare is not the most straightforward market to size. We're talking about an age demographic and a massive horizontal cross-section with a lot of geographical, financial, cultural, and therefore behavioral variation. After spending some time with consumption data, we took urban elders as a rough proxy and looked at their consumption expenditure, excluding categories such as food, rent, educational spending. The sandbox within which this thesis plays takes into account expenditure on health, consumer goods and services, and discretionary spending. This gives us a working market size of around $13 billion. It's important to note that urban elders are not the perfect proxy for paying elders. Because we're talking about a demographic and not a sector, the size of the market is not the best indicator of the real consumption opportunity in this space. 3 reasons. 1, this idea that elders don't spend on themselves, which is largely true, especially beyond health. Second, there is a huge variation by category, which is to say that health versus non-health spending is significantly different. And third, children spending on their parents in these categories is not accounted for by the sizing. The larger context here is that this thesis is written in response to some conflation of the demographic change with a commensurate expansion of consumption opportunity, with a lot of optimistic thinking around digital adoption in the elder segment. So the idea is to nuance that a little bit, starting with a framework to explore ability to pay in this segment, comprised of 3 levers: net worth, liquidity, and financial autonomy. This data is from a massive survey conducted by the Age Well Foundation, which is the best resource that we could find aside from the Lassie study. In a lot of the discourse around the silver economy, we hear elders spoken of as ideal consumers with a lifetime of savings. That's not necessarily the case yet. Only 9% of elders, according to this survey, have a net worth of over 50 lakhs. The other lever is liquidity. Elders are far less liquid than any other demographic. More often than not, their assets are tied up in real estate or long-term investments. Third, this idea of financial autonomy. Do they have it? Do they decide where the wealth they hold goes? Yes. While the vast majority of elders are financially dependent on children or family to some degree, most say that they do have spending autonomy. But here, when you look at the breakup of spending, only 20% is discretionary and over 30% is on health, which is anywhere between 1.5 to 3 times that of any other age demographic. So this is where the sharp differences in expenditure by category start to become clear. Health spending is king. Looking at the children of elders in conjunction with trends in migration and nuclearization reinforces this emphasis on health plus plus. The diaspora is 64 million strong, 2.5 million emigrate every year. Even on the domestic migration front, 52% of Indian households are nuclear households. The vast majority of this migration is educationally or professionally driven, which has certain implications for ability to pay, which is that it's higher. If we look at the middle class and above segment of India, each successive generation makes more, is migrating for better opportunities, and overall is able to pay more. Children pay specifically for the needs of their parents. Largely, this is healthcare. Children who live away are also willing to pay for what mitigates their guilt or their worry, their information deficit, and also their own convenience as they take care of their parents. In essence, a broader care continuum is what they're willing to pay for. So effectively then, these areas of existing spending, health, will see more spending. There might be a few other ancillary areas, offshoot areas that children might be able to and might be willing to pay for where they haven't paid before. From this arise what we see as the three buckets of opportunities in eldercare. One is areas of existing spend, which is your traditional healthcare experience. Here, anything that can enhance convenience, access, quality, etc. is where you might see more spending, in addition to the increase in spending that's coming from a higher incidence of lifestyle diseases and so on. The second is offshoot spaces like ancillary healthcare, newer services that expand the healthcare experience. Home care is one example. Both of these buckets comprise the healthcare piece. And then the third is discretionary spending, your more traditional consumption spending. So whether it's financial products, social spending, brands, other products and services, anything that's discretionary is the third piece. So the first piece, which is comprised of the first two buckets, is healthcare. We talk about both offshoot and existing spaces. Offshoot spaces are essentially out of hospital care, so this could include home care, assisted living, other services. The second piece is the traditional healthcare continuum, including and arranged around hospitals, where there are a lot of broken links and white spaces that new specialized services can smooth over and mitigate. We size the elder health market at $6 billion USD, which is on the back of out-of-pocket spend. Now, the need for healthcare expenditure, especially in this demographic, is clear. In 2018, somewhere between 50 and 60% of elders had one or more morbidity. Around 40% have one or more disability or mobility-related impairment, and around 30% exhibit depressive symptoms, although this one is difficult to quantify. We also struggle to provide adequate care. For one, we lag behind most developed and developing nations on several key infrastructural and personnel metrics, from hospital beds to physicians and nurses. Affordability is also a huge challenge. Public health expenditure is not optimal, and out-of-pocket expenses are higher than in comparable countries. The out-of-pocket burden only increases as a patient transitions from primary care to inpatient or more specialized care. Insurance has not yet become the solution. Around 1.4% of Indian elders have private health insurance coverage, which is also an optimistic estimate. And this coverage is less than ideal. Chronic conditions are often excluded. Premiums are higher the older you get. Other forms of care, such as home care, for example, are excluded. Insurance is truly the key that can unlock the elder care market, the most important piece of the puzzle that's suboptimal in adoption and impact today. In addition to all these infrastructural and financial barriers, hospitals are disincentivized to offer long stays. The ideal length of stay, from the lens of average revenue per bed, is 72 hours. This is the number that hospitals try to get to, especially now that the focus on expansion has dimmed slightly and average revenue per bed is king. So due to a mix of these factors, less than 8% of elders in India avail inpatient care, which makes out-of-hospital care a more attractive solution. Now, to map opportunities in out-of-hospital healthcare, we introduce a 2x2. One axis is the intensity of care provided, high touch versus low touch. The other is where the care is provided, at home versus at a facility. To begin with, we explore the high-touch care opportunities, home care and assisted living. In home care, basically, there are two phases. The first phase is the more straightforward nurse or attendant services, so Portia, HCAH, Apollo Home Care. What they've done is consolidated the supply of nurses and attendants, and they remain the suppliers, even for phase 2 companies. However, it is a very low gross margin business. The majority of them, until a couple of years ago, had negative gross margins, even after well over 5 years of operations. What phase 2 companies like Imoha or Samarth have done is built a wrapper around the attendant/nurse model. By adding a variety of value-added services, they get blended margins. They're able to expand gross margin in a way that phase 1 companies find difficult to do. And with these services, they create a full stack sort of positioning that caters to and appeals to some of these convenience pain points that children abroad have or children living elsewhere have. This is what the margin maximizing phase 2 model looks like. At the bottom is what Portia and Nightingale already do, as well as some local vendors, which is provide attendants and nurses. The newer players outsource that piece to these players like Portia. So they're not responsible for training. They don't contend with any of the supply issues. In addition to becoming an intermediary for the attendant piece, they provide relationship management, concierge services, and a kind of community piece, which could be offline or online. Some of them have apps that have group chats and workshops, etc. This entire proposition is so far a highly premium proposition. As you can see on the top right, when the attendant nurse service is outsourced, these newer players are able to charge a premium and have a higher take. They also look to optimize the service mix. Many of them are, for example, moving towards providing more expensive services, longer term and or more specialized forms of home care. For example, palliative care or home ICUs. So the mix continues to change and evolve. And then of course, there's a lot of upselling or bundling. Average revenue per customer for Portia was just around north of 10,000 a year a couple of years ago. For these newer players, subscriptions can start at 10,000 a month and climb much higher. There are a couple of things that stay our hand on this space, but first the positives. This is an inevitable sort of market, right? And in the long term, it could be a very exciting opportunity. It is also a great growth channel for other elder-focused products or services because of the very concentrated, sort of very high-intent audience. However, there are a host of players doing this with similar playbooks, similar propositions, attempting the same kind of horizontal expansion in services, which could lead to cannibalization. Even for the 2 or 3 winners that seem to be emerging, CAGR has been low. So the way we see it, either they continue to do what they're doing at this rate of top-line growth, or they expand even further to non-home care, which a few of these players have begun to do with assisted living facilities. We talk about this in the next slide. There seems to be a clear age divide when it comes to home care and assisted living, even though there is of course some overlap. A number of assisted living players we spoke with told us that the majority of elders availing their services were in their mid-70s or older. Home care, on the other hand, is much more diffused across the age spectrum and also across a variety of use cases. This then creates a sort of pipeline effect, and offering both types of care can capture and retain the customer across their care journey. A whole host of companies are already doing this. Max Antara, HCAH are 2 players that offer both, 2 large players that offer both. Among the newer players, Imoha acquired Epic Assisted Living in 2021. Assisted living is an interesting proposition because the demand as it stands now is higher than supply. According to folks in the industry, there are only about 20,000 good quality premium-ish beds in India. The demand is ostensibly higher. At least 17% of elders live without children or other family members. 4 million have dementia and so often require more care than children are able to provide. And an estimated 8 to 10 million require palliative care. So it stands to reason that there is demand that isn't being fulfilled. However, there are a couple of things that complicate this. One is there is a lot of stigma. South India does better for a variety of reasons. Anecdotally, it's a more established proposition there, and we've taken senior living residential projects as a proxy to sense check this. But again, there aren't many private assisted living facilities, and the majority of them are standalones. So really, the play here is consolidating this very fragmented market and building trust by standardizing or improving quality and breadth of services. However, in doing so, existing offerings have positioned themselves at the premium end of the segment. It's easy to see why pricing down will deal a blow to unit economics, but in staying premium, you box out a large segment of the market while facing headwinds like stigma. So the more unaffordable you make it, the more you throttle demand, and that kind of becomes a self-fulfilling proposition. So 1, pricing is challenging. 2, it's a very classic services model. There's not a lot of operating leverage. So again, as an investment opportunity, while there is long-term conviction, it's yet to come into its own. Now, the second set of opportunities, those that fall broadly onto the low-touch side of the spectrum. These are, for the most part, white spaces with room to build. First, we look at low-touch care at facilities, essentially specialized services to tackle what's broken in the chain of care. Second, we look at full-stack care at home, which is using tech to bolster care provision at home. So specialized services, 3 buckets. 1 is navigating hospitals. From billing to physically navigating the space to making sense of your diagnosis, all of that can be confusing and exhausting, especially for elders. A hospital buddy service can go a long way. There are already large hospitals that provide this, as well as volunteer groups at the grassroots level at, for example, district hospitals. But still, they're few and far between, and a broader offering could appeal to elders and beyond. The second is streamlining care. There are far too many specialists that elder folks have to visit, which can be, again, confusing, exhausting, not to mention expensive and disjointed. We think geriatrics as a discipline is an incredibly exciting opportunity. A dedicated geriatrician can look at health concerns and the interplay between them in the context of the elder as a whole. They can coordinate further treatment as required and make the process easier and more accessible overall. There's an end-to-end opportunity here. 1, on the training and education side. India only gets 20 new geriatricians a year, and only 8 major institutes provide the MD in geriatric medicine. Second, as a verticalized chain of clinics opportunity. And the third sort of specialized service is one that can address a gap in the care continuum, including both hospital and home care as well as others. So maybe you need something that's more low touch even than home care, or something that tackles elder loneliness and introduces a community aspect to care, like elder daycare, for example, or some of the online models like groups and communities or emotional support providers, although these online models are yet to prove monetization. Now for the low touch at home piece, which is essentially the product piece. If you think about the home care stack, you have your attendant or your nurse or your family member, whoever's the caregiver, and then you have some kind of elder proofing. And then you ideally would want some kind of fall detection and emergency response. And we all know this. Elders falling is a huge problem, resulting in everything from injuries to fatalities. The way people often think about solving this is through traditional wearables like your smartwatches. But here's the thing, elders don't wear them. In the US, only 3 to 9% of elders use them, so in India it's fair to draw the conclusion that the share is much lower, virtually non-existent. Cameras are too invasive. So there are a bunch of companies innovating on this. They offer radar-based fall monitoring. These are non-invasive and then also alert some sort of emergency response mechanism or ambulance system to close the loop. There's one in the US called Cherish, and there's one that just emerged from stealth in India called KuboCare. Talking about products, there are a couple of other opportunities that we've identified. On the products plus services side of things, we've looked at hearing as an example. It's very underpenetrated, very fragmented. There's a lot of unaddressed demand as well as a lot of latent demand. Further, the referral chain is broken. Doctors aren't necessarily directing you to a product or a place to buy it. There's room to build a real brand here with a truly asset-light clinic model. Earcart and HearClear are already doing something like this. You essentially need an audiologist with some assessment tools and a chair, basically. There's consultation income and commissions on the sales of high ASP product. Good quality hearing aids start at around 20,000, and the really good ones are at around 80,000 to 1.2 lakhs. So there's an opportunity to build a good, verticalized, specialized brand. There's also a lot of room for a horizontal, general needs brand. Let's take health-adjacent product needs like durables, wheelchairs, walking sticks, you name it. These products are highly commoditized, and sifting through the thousands of options on Amazon or local markets is time-consuming. There's a trust deficit and a convenience deficit for both elders and their children who might be doing the choosing and the buying and the ordering. Now, the attempted solutions that have emerged are sort of the creation of specialized marketplaces. We think this is tough though, because it's not Amazon necessarily that people don't trust. It's the product brand that needs to be solved for. So there is brand building opportunity here that hasn't been tapped. This could extend, of course, far beyond durables, but we think durables is the wedge. It can be positioned as premium, allow for customization, and run the gamut from the white label to the modified to the carefully developed. Which brings us neatly to the broader discussion around building brands, consumer brands, discretionary spending, specifically for elders. We haven't seen anything really stick in any category aside from maybe Saregama Karma, and for good reason. This is a demographic with all the complexities and habits, preferences and experiences that you can imagine, and catering across this cross-section is hard. But where can brands be built within this segment? Now, the WHO uses a handy age-based framework for introducing some nuance within this demographic. They divide the elderly into the young old, the older old, and the oldest old. The elderly are not a monolith, and we think the Goldilocks segment for building consumer brands here is the young old. We borrow the term and modify it to refer broadly to those under 65 at present, and also the soon-to-be old, so those 50 and older. This demographic is very mobile, has a high level of digital comfort, have been active consumers and discretionary spenders for a while. Crucially, they're also actively planning for their later years. The caveat here is this is obviously a mid to high income, sort of largely urban young elder. That's the sandbox. And so basically this is the demographic for whom that third box of opportunities, the discretionary spending bucket, opens up. An example of a unique opportunity that exists largely for this demographic is financial planning or estate planning. The need for products that simplify and enable this is massive and urgent. India has around $5.3 billion tied up in just bank accounts that are sitting unclaimed. And if you include things like deposits, property, other financial instruments, these numbers go way up. This is not a niche H&I problem. This is a middle class and above problem. Again, the opportunities here are nascent but illustrative. We think the young old is the subsector that will open up the kind of elderly discretionary consumption that people are talking up today. The downstream effects of that are still a few years away, but these opportunities serve as indicators of good things to come. Overall, there's high conviction on latent demand and the inevitability of this elder market, and this thesis is an exercise in kickstarting our thinking on this demographic and a foundation upon which we hope to build further views as the landscape evolves.